All right, now it's working. Good afternoon. Hi, how are you? Dr. Randy Fink here, CNY Fertility, Colorado. Very happy to have everybody with us today. We had a little bit of a false start there on the Instagram side. Uh, I know, hard to imagine that technology sometimes isn't working the way it's supposed to, but now we are. Nice to see everybody. How are you, Mrs. Coleman? Nice to see you. Lashes by Brittany. We've got, oh gosh, it's just everybody showing up here and on the Facebook side as well. We're also on LinkedIn Live today. So coast to coast via internet, it's the CNY Nation, and I'm Dr. Randy Fink, live from Colorado Springs, and this is Fertility with Fink. Ordinarily, it's Fertility with Fink and Friends. Today, I have no friends. It's just you guys. So thanks for being my friends. Here's what we're going to do. We're going to talk about some things fertility. We are going to answer your questions, and we are going to talk about everything that's on your mind for the next, let's say 45 minutes or so. Feel free to throw in a question there. Hi, everybody. I'm not sure anybody's on the Facebook side, but it sure does look like Instagram is live. Hi, just waving at everybody. I wish I could press the button, but I can't seem to get there fast enough. You know, one question that I had, and I see that I had it emailed to me, and it was a question about pap smears. And of course, that's every girl's favorite test. I always say it's our most popular exam, you know. Does the pap smear have an effect on my fertility treatment? And the answer to that is probably mostly not. Hi, Cecilia. Nice to see you. The answer is probably not. So the pap smear is a screening test for pre-cancers of the cervix. And another time we can go a little more detail on pap smear results if you'd like and what that all means. But it's part of your regular checkup, part of your regular examination. Generally, these changes in the cervix are caused by the HPV virus. HPV, the human papilloma virus, is like the common cold of the vagina. So it's said that about 80% of us will have had some exposure to HPV at some point during our lives. By the time we turn 50. It's really most people. The risk factor is having had more than one sexual partner in your lifetime, or being with someone who's had more than one sexual partner in their lifetime. So that turns out to be, really probably most of us. That said, HPV can cause changes in the cervix that ultimately are precancerous. Fortunately, cervical cancer is a relatively rare disease in the United States, and it happens probably 3,000 to 4,000 times, 3,000 to 4,000 women, in the millions and millions and millions of women who are tested for precancers of the cervix. So pap smears are very, very effective in preventing the progression to cervical cancer. The presence of an abnormal pap smear is something that you want to have diagnosed, like what's going on there. When you have an abnormal pap, you have a procedure that's called a colposcopy. And that's where we take a look at the cervix with a pair of binoculars or a microscope. We place some vinegar onto the cervix that causes cells that are abnormal to take on a different appearance. And when we see those cells, we can sample those cells, and they come back to us with certain results, different types of precancers. Well, the good news is that the progression of those things is so very, very slow that even if you have an abnormal pap smear, it's a 10 to 15 year climb up the ladder to reach something that's abnormal enough to really be a threat to you. And so therefore, these are things that are often at your initial pregnancy visit, your doctor will perform a pap smear. These changes in the cervix are not typically not functional changes that will cause any effect on your fertility. So keep up to date with your screening and don't worry about that part as it pertains to your ability to get pregnant. I saw hi, everybody, glad to have you here. Oh, Melissa Maloney, my second transfer worked. Outstanding. I'm so happy, Melissa. Thanks for telling us that. I saw a question there. I'm interested in the IVF process. How do I get started? And that's a very good question. It's a common question that we hear. You get started by picking up the phone and calling us. After we've had our consultation where we think about what's going to be the right dose of medication for you, we typically will take care of prescribing that medication depending on where you are. If you're outside of one of our immediate local areas like Syracuse, Albany, or Buffalo, or in my case here in Colorado Springs, then we have a team that's called the Global Travel Team. Global Travel, these are the folks that get the medications in your hands. They teach you how to use that medication, and then they set up your monitoring. The monitoring for IVF, which is a series of ultrasounds and blood tests, can be done locally near your home at your own OBGYN's office. It can be done at a local hospital. It can be done at any imaging center. Sometimes it's even done at another fertility clinic, and that's okay too. The global team takes care of getting those results back to us and following your cycle and making changes that are needed. And then you come to one of our centers for your retrieval. When we retrieve the eggs from the ovaries, we like you to get to our center, if you're coming from out of town, at least the day before, so that you don't have to stress over travel. Travel has become such a nightmare in this day and age. You don't have to stress so much over travel. And then my recommendation is always to stay overnight after the retrieval so that you're here in case you're not feeling well, that at least we are close by and can help you if you need to. What we do then kind of depends on what you're going to do with your embryos. So we grow the embryos up from 3 to 5 days typically. A day 3 embryo is called a cleavage stage embryo. A day 5 embryo is typically what's called a blastocyst. Now, a blastocyst is sometimes happens on day 5, sometimes on day 6, and sometimes even on day 7. The blastocyst is more likely to get you a baby, because a day 3 embryo is what we call a cleavage stage embryo. And basically what that is that the sperm has fertilized the egg in the lab, and those cells are continuing to divide. So they're cleaving, they're dividing. Once the embryo becomes a blastocyst, it's actually a little functioning machine at that point. It has survived metabolically to a point where it is a little living organism. And so therefore it has a higher probability of being able to get you a baby. So if you can get a blastocyst, that's fine, but, and it's a very important distinction because CNY has different feelings about this than many other practices. A day 3 embryo, there is nothing wrong with a day 3 embryo. And if you are limited in the number of your embryos all day long, I would rather see you getting that embryo placed back inside of you where at least it may have a chance to grow, whereas it might not otherwise grow in the laboratory. Your uterus has the magic sauce, as I like to say. No matter what we do in the lab, no matter how good our lab is and the embryologists are, no matter how state of the art the entire apparatus is, your uterus is still the best place for an embryo to be. So if we're limited in the number, we would like to see that embryo go back inside of you on a day 3 basis, as opposed to trying to grow it to a blastocyst stage. So our CNY protocol, and you'll hear when you come for your treatments here. Our protocol is if you have 5 or more embryos, we will recommend that you grow them to the blastocyst stage. If you have 4 or fewer, we recommend that you do something with them on day 3. Now, we were talking about what the options were. After you've had your retrieval, you can do a fresh transfer. A fresh transfer is where we can place the embryo back inside of you that very same cycle that we've done our stimulation. In CNY's case, a fresh transfer is included in the price. There's no extra cost for it. So that's potentially a good thing. But there are some situations where your body tells us that doing a fresh transfer is a mistake. Because imagine through that process of stimulation to get the eggs from your ovary, you are very much in egg making mode. And when you're in egg making mode, that may preclude you from being in getting pregnant mode. And if that's the case, the numbers will tell us that. And we will suggest to you that the numbers are saying that you're probably not going to be successful. And in fact, it may even be dangerous to do a fresh transfer. And in that situation, we will tell you, please don't do a fresh transfer. Let's do a frozen transfer instead. And it's kind of funny because people think about, well, when I go to the grocery, fresh vegetables are always better than frozen vegetables. So shouldn't a fresh transfer also be better than a frozen transfer? And the answer is no. At the end of the day, the results should be equivalent, but you will see that there's a slight increase in the chance of success with a frozen embryo transfer over a fresh transfer, because there are some people who get fresh transfers whose bodies are actually telling them that they shouldn't do it. That they're really more in egg making mode than anything else. So fresh versus frozen, it's whatever is the right choice for you. If that first embryo, for example, doesn't work in your fresh transfer, the remaining embryos are stored for you. They are there and waiting for you. They're kind of hanging out in what we'll call suspended animation. They're really good forever. They're yours forever. And you can come back at any point. As those of you who have been through the process know, it is way easier to do a frozen embryo transfer cycle than it is to do a whole IVF cycle, really for sure. Here's a question I'd like to answer from Andrelina. What is the take on a 3-day fresh transfer? So we talked about fresh transfer. We talked about the day 3 transfer versus a blastocyst with an over 10 millimeter lining, but not trilaminar. So let's talk about that trilaminar thing. The trilaminar endometrium is 3 laminar layers. It's a 3-layer endometrium. And when we look at it by ultrasound, it almost looks like, that's a great look. I hope somebody screenshots that. It's 3 layers, almost like a set of lips. There's a top layer of the lining, there's a bottom layer of the lining, and there's a bright line between those 2 layers. And so it has the appearance of being 3 layers. And that shows us that you are ideally estrogenized and progestinized, the 2 hormones that talk to the uterine lining. That tells us that you're ideally hormonally situated for a transfer. Now, sometimes the lining will not be trilaminar, and that doesn't mean it's not going to work, but it means that the receptors inside the endometrium, that is the little antennas that receive the signals from the hormones, may not have made that the most perfect environment. Again, a transfer can still work under that circumstance, and so that's something we want you to talk with us about, whether it's the right decision to proceed. Is there a lining that's too thick? Well, there's certainly an endometrial lining that's too thin, right? So if you have an ultrasound and your lining is only 4.5 or 5 millimeters thick, then that tells me, whoa, the inside of the uterus was not listening to what the hormones were telling it. It hasn't grown to the point where it is going to serve as the ideal baby blanket. And that's really what it does. We place the embryo in, it envelops the embryo and allows that embryo to grow. If the lining is thin, it's probably not going to work. Is there a lining that's too thick? Technically speaking, no. But when I see a very thick lining, it starts making me worry that there's something else that's going on inside the endometrium, like a polyp, which is, of course, a finger-like growth of tissue that sticks up like a tree trunk or hangs down like an icicle. It makes me think that there's some kind of growth inside the uterine cavity, and so we certainly want to be able to investigate that further. So I hope that answers your question there. I saw another question over here. We're getting lots of questions on the Instagram side, so thanks for your patience here. This comes from Alex Navarra. Alex, hi, how are you? Thanks for being with us today. How can you prevent OHSS? And are you at higher risk if you've had OHSS with a prior retrieval? OHSS is a very important thing to talk about. And Alex, gosh, I really appreciate you bringing that up because it's something that I am willing to, or that I am wishing to. Holy cow, I just got distracted by Tina Fink. Tina Fink is not my cousin, although every time she comes here, I tell her maybe she is a long-lost cousin. Tina's transfer stuck. Congratulations. That makes me so happy. Thank you, Tina, for telling me that. Boy, I got a little distracted there. Were we talking about something else? Oh, right, OHSS. Ovarian hyperstimulation syndrome. The reason OHSS happens is because we know with the process of IVF that we are stimulating the ovaries, and in each follicle, in each little egg house. So right when we have the ultrasound and we see those little spaces that some people call cysts, if you go to the emergency room with pain, they will call them cysts, but those are follicles. Those are eggs that are waiting to get released. The egg is in there, the fluid is in there, and it's lined by some little cells that are called granulosa cells. Granulosa cells. And the granulosa cells make estrogen. Well, if you have made an awful lot of eggs, let's just say, let's just say, as I tell people when they come here, your ovaries paid really good attention to that medication we gave you. And if you make yourself an awful lot of eggs, then what can happen is the granulosa cells inside each follicles are making themselves a lot of estrogen. And as that estrogen level goes up, that is what causes ovarian hyperstimulation syndrome. And there's two things that happen with OHSS. One, your ovaries get really big. So no question, they go from being, probably about that size to sometimes, being about that size. And when they get that large, it can be very uncomfortable. Bloating often gets worse before it gets better, even in the best case scenario with IVF. So ovaries get big, and it takes them a little time to be able to shrink back down to normal. And since during that retrieval, we use a little needle in order to be able to retrieve the eggs from the ovary, when the eggs come out, it leaves behind a space, and your body hates empty spaces. And so it wants to fill that space with blood. So that leaves big, bruised ovaries. And that's really what it is, big bruised ovaries, and they can be uncomfortable. So usually we send folks home with some pain medication and some nausea medicine, because big ovaries can also kind of make you feel nauseated. So in addition to having, I'm going to see if I can fix this here a little bit. In addition to having very large ovaries, all that extra estrogen can do things to us that may not be so good. It makes us retain water. So there's often a lot of extra fluid inside the abdomen, which we're able to drain off, which will help you to feel better, but oftentimes that fluid will just return. And so we advise you to drink a lot of protein, 200 grams of protein, which is a lot of protein. That's protein shakes can be really hard to drink when you are full and bloated and you're not hungry and you don't feel well. 200 grams of protein is what we recommend because that convinces the kidney to help to get rid of some of that extra fluid that you're retaining. My colleague, one of my colleagues in Albany, tells patients, and I've learned this, and I think it's a great thing: Chinese food and Gatorade. Chinese food and Gatorade. So you're getting a little protein with the Chinese food, but you're getting sodium, and that's going to tell the kidneys to try to help get rid of some of the fluid. And the Gatorades, the electrolytes. So in general, that's a good way to kind of help yourself feel better. The OHSS, the syndrome itself, typically doesn't reach its peak until about 5 days or so after the retrieval. That's really when it gets the worst. So there are a lot of people who feel like they have ovarian hyperstimulation syndrome, or they worry that they do, when in fact, really what they have is just big ovaries that are very uncomfortable. In the olden days, people would get extremely sick from OHSS. It could make you retain so much water that you get water around the heart, that you get water around the lungs, and that you could even get fluid in the brain, what we call cerebral edema, that would make people be in a coma in the ICU. In the modern day, that's very, very rare because we know how to recognize OHSS, we know how to treat OHSS, and more importantly, we know how to prevent it. Lower doses are better. So many of you can attest to that in your own IVF journeys, that you may have gotten a high dose of medication to try to stimulate your ovaries, and you may not have gotten a great response. But then when we tried lowering the dose of medication, you got an even better response. So less is often more when it comes to IVF, and that's really how you can prevent OHSS in a cycle. If you've had OHSS before, it tells me that you are at risk for it happening again. And so anytime I look at dosing, I always think, okay, we're going to need to lower it because we're going to try to do better this next time. Now, one thing I do tell people about that is I don't need you to have 50 eggs retrieved during your IVF. It's just not necessary. The data shows us that anything more than about 15 eggs in a cycle really doesn't improve the outcomes. So there's no need to use very, very high doses because, again, 15 or fewer is really what we're seeking. So, Alex, thanks for that question. Sure do appreciate it. Hey, here is another good question. Boy, we're getting some good questions over here, and I'm sorry that it's taken me a little time to be able to get to some of these things, and we'll do the best that we can today. Grace would like to know, how important is sperm morphology for pregnancy and a live birth rate? Morphology means, what does the sperm look like? So somebody's job is to sit and look at a microscope and tell us what they think the sperm looks like. They have necks, they have heads, they have tails. In addition to, are they swimming in the right direction, and how many of them are there? What do they look like? So what's normal is that up to 96% of your sperm can look abnormal. Does that make any sense to you? It's hard to really rationalize. It's hard to really understand, except when you think about that a normal ejaculate contains, a minimum of 15 million sperm. So to have 4% normal forms means that they can probably get where they have to go. Morphology is one of those things that is very subjective, that it may be difficult to reproduce the number from one andrologist to the next. So, from one professional who is looking under the microscope at your sperm, you may get a very different number when it comes to somebody else looking at your sperm under the microscope when they're saying, what does that sperm look like? So, one, it may not be reproducible. Two, abnormal morphology is typically not considered to be a cause of infertility in nature. So it may be associated with what we'll call subfertility. So in a fertility population that's coming to see us in an IVF clinic, it's not uncommon for us to find a large number of individuals with abnormal morphology, which is what we call teratospermia. Spermia, obviously meaning sperm, and terato, a teratogen, something that is that doesn't look normal. A teratogen is a medication that's actually like a poison that causes a birth defect. Teratospermia means the sperm doesn't look normal. So it's common for us to see in an infertility population, because again, it may be associated with subfertility, but it is not considered to be a cause of infertility. And as it pertains to IVF in particular, that is typically something we can quickly overcome with our process. Okay, let's go back to the Facebook side here. Hi, Eugenia. Thanks for being with us. By the way, if you just joined, oh my goodness, it's already almost 4:30 in the afternoon Mountain Time, which means almost 6:30 on the East Coast. Hi, CNY Nation. Dr. Randy Fink here, live from Colorado Springs, answering all your questions, talking about women's health and fertility. Bring on those questions, my friend. Every Tuesday night, Fertility with Fink and Friends. Sometimes we have people join us here who can provide interesting conversation. But tonight we're focusing on you. So throw it my way, and if I can get to it, we'll be delighted. Eugenia says, recently had a hysteroscopy that showed some small polyps. Interesting. So normally when we do a hysteroscopy is when we place a camera inside the uterine cavity in order to take a look. When we look inside, if I see a polyp, then I'm going to remove those polyps. So for me, it makes way more sense to make the hysteroscopy both a diagnostic and a therapeutic procedure. So it's a little concerning to me, Eugenia, that you had a hysteroscopy and they didn't take care of anything. Now, in some places, they'll do a diagnostic hysteroscopy just in the office, a quick 15, 20-second procedure to take a look on the inside without the intention of treating anything. So maybe that's what happened there. But usually in the presence of a polyp, it means that we want to go back in with the camera to remove those polyps. An endometrial biopsy, per se, when we use that term, I think of it as something that's typically done in a GYN office where a tiny little straw goes in and sucks out a little piece of tissue for diagnostic purposes, and is not usually something that can be used to remove a focal growth like a polyp. So I would recommend that you consider having a hysteroscopy to remove those polyps, and then they will be able to both get tissue for diagnosis at that time and to be able to treat you. Okay, let's see if we have here. Is there anything we can do to increase our chances to get blastocysts? You know, it's another great question. And this is the thing I tell people about this IVF roller coaster. It's a numbers game. It's a numbers game. It's about doing what we can to get the best eggs and the most eggs with the best quality in order to make the most number of embryos and the best high quality embryos, in order to give ourselves really the most options. So One thing that we think about is priming. Priming is something that we will typically use for folks who have a diminished ovarian reserve or in folks who have undergone a cycle of IVF and maybe haven't done as well as we'd hoped. Priming involves using some different medications in order to get the body ready for another cycle of IVF. Typically, the medications that we use for priming are estrogen and progesterone, mostly estrogen. This is kind of the mainstay of priming. And the reason for using estrogen and progesterone is because they are the language that the ovaries speak. It increases the blood flow to the ovaries, which increases the body's ability to get those medications we use to the ovaries to stimulate the production or the recruitment of eggs. So estrogen, progesterone. We also typically will use low-dose naltrexone. If you've been through the process, maybe you've used low-dose naltrexone. And what it does is that it stimulates your body's production of endorphin. Endorphin is that feel-good chemical we get in the brain, right? Do you know the most common side effect from low-dose naltrexone? It's actually, well, I mean, I don't know if it's the most common because anytime you take a pill, it's common to nausea and stomach ache and, those kinds of things can be very, very common no matter what the medication is. But from the medication itself, it's having weird dreams. And that's why we tell you to take the medication at night because as your endorphins increase, it can make your brain feel pretty good. So for what that's worth, low-dose naltrexone, increasing the endorphin also helps at the level of the ovary. And of course, omnitrope, which is human growth hormone. Growth hormone is what keeps us young. Right? Growth hormone may have the ability at the level of the ovaries to repair or help our bodies repair some of the age-damaged DNA. So how do we get better blasts? Well, we have better eggs to begin with because growing to blast means that we have more potentially normal embryos. How do we get normal embryos? We make better eggs. So I would think about priming as it pertains to getting better blastocysts. Let's see what else we have here. If I can answer something that might be of interest to everybody. What are your recommendations for this? Comes from Beck Ed 80. Hi, Beck Ed. What are your recommendations for someone who has amazing labs and procedures? Husband is perfect as well. Of course, your husband is perfect, right? He found you, right? You are 42 and had 7 failed transfers. You have Hashimoto's, hypothyroid, no weight issues. Well, you got a couple of things going on there. Probably the biggest issue is that, of course, as we mature, the DNA in those eggs becomes less stable. So it gets harder for us to produce normal embryos. So if you had 7 failed transfers, I would start to think, well, this is likely going to be, at least some component of that may be an embryo issue. Are we making chromosomally normal embryos? Because when folks miscarry or when embryos don't implant, most commonly the reason there is because there is something functionally not right about the embryo itself. But you have an interesting addition there, Beck Ad, and that is you have Hashimoto's. If you're not familiar with Hashimoto's, it's just a fun word to say. So I think you should all probably try to say it in the privacy of your own homes. Hashimoto's is autoimmune thyroiditis. Thyroiditis. Autoimmune thyroiditis. It means where your own immune system mounts an attack against your thyroid gland. That is the most common reason that folks will end up being hypothyroid, and that's when the thyroid is functioning too low, its volume knob is turned down. Many medical endocrinologists will not recognize isolated Hashimoto's as being something that can make you feel bad, but in functional medicine circles, it absolutely, we believe it absolutely is. So you may not feel well as a result of having Hashimoto's, but certainly you're overtly hypothyroid now, Beck. So that says to me that one, the thyroid's something that we have to fix, but the Hashimoto's tells me that you also have inflammation. Inflammation is probably the thing that stands in the way of almost every fertility journey. And Dr. Kiltz talks extensively about inflammation and how keto and carnivore diet wise is used to treat inflammation. There are some other supplements that we can use that may also help with that. But please take a look at some of Dr. Kiltz's work on keto and carnivore as it pertains to inflammation. But Beck, that's something that I would definitely think about. And you did have a successful pregnancy, and he's 3.5. What a great age! Really, one of my favorite ages. The terrible threes. It's just really so much fun. Looks like you know what? I can't really read that name there. Jab Neil Diaz Mena had a retrieval last Saturday at Syracuse. You see, you didn't come to Colorado. That's your first problem. I'm just saying. I think it's a much nicer place to visit, but hey, that's just me. The 3 eggs didn't mature. Oh gosh, that's very frustrating. The first retrieval, you had 8 eggs with 6 fertilized, but only 1 made it to day 5. Now hoping to do my new do a new cycle. What can be done differently? So if you got eggs that didn't that weren't mature, the first thing I would want to look at is how you were triggered. So usually when we give the trigger shot, which is either Lupron or HCG, or sometimes a double trigger, which is when we use both Lupron and HCG. And what that trigger shot does is it tells those follicles in the ovary, we're coming for you. It means that we are ready to get the eggs from those follicles. Now, in nature, what happens, we talked about the fluid that's in the follicle there. It kind of functions like a squirt gun and goes and squeezes that egg out. The egg would normally get taken up by the fallopian tube. Sperm would swim into the fallopian tube and the two meet, and that's how you create an embryo. But in our case, with IVF, what's happening is that we don't want you to release the egg because we want to retrieve the egg. The egg hangs out in that little follicle, almost like on a little stalk. So it kind of sits there sort of like this. And when we give the trigger medication, it tells the stalk to fall away so that the egg is waiting for us to come and retrieve it. We typically trigger you based on the size of your follicles. So it makes me wonder if maybe next time, since your eggs were immature, we might wait a little bit longer to trigger you than we might otherwise normally do. So I hope that helps there. Let's go to the Facebook side here. Hey, Cecilia, you are on estrase now. Estrase is estrogen, estradiol, and you are priming for your upcoming first IVF cycle. Outstanding. Well, congratulations and welcome to the journey. How is estrogen different from progesterone? And that's a great question too. So estrogen and progesterone kind of balance each other out in the body. So estrogen, in fertility terms, serves the purpose of causing the lining of the uterus to grow. So under normal terms, you get your period, and then you start to grow a follicle. You start to grow an egg. There's several eggs that are all competing with each other to see which is going to be the one that's going to be the boss. And that we call the dominant follicle. So every month or every cycle, you develop a dominant follicle. And that dominant follicle secretes estrogen from, do you remember what it comes from? We talked about it before, the granulosa cells in that follicle, they make your estrogen. The job of the estrogen is to thicken up the lining of the uterus so that it makes a nice, spongy, warm, juicy place for an embryo to implant. Progesterone tells the lining, okay, you're thick, but now we got to get you ready to bring on that embryo. So, in a natural cycle, the progesterone balances out the estrogen. And at the end, if it realizes that you're not pregnant, the progesterone level drops. And that's the signal for you to say, shut off the hormones, clean everything out. We're going to try again fresh next month. And that's obviously why you get your period. So when we give you the estrogen, we want to balance it out with some progesterone, and that's why we rarely use progesterone alone unless it's for a very short term in order to get the lining built up. If we get too much estrogen and no progesterone, that's called unopposed estrogen, and that can really actually cause an overgrowth of the uterine lining, and that's something that we want to avoid. So hopefully that helps here. Oh gosh, another easy question. How long does it take to get genetic testing on an embryo? Well, so first of all, to get an embryo that's suitable for genetic testing, we have to grow it to the blastocyst stage. They have to grow to blast, so we're using both nature and science to kind of help select which are the embryos that may be more likely to get us pregnant. So nature helps because we can't do it on a day 3 embryo. And if the embryo stops growing at day 3, then we're not going to be able to biopsy that embryo. It has to grow to blast. Once it's grown to the blastocyst stage, the portion that's biopsied is called the trophectoderm. And the trophectoderm is the part that becomes the placenta. It's not actually biopsying the baby, it's the part that becomes the placenta. They send that off, and it takes generally anywhere from about 10 days to 30 days. So, probably a week and a half up to 4 weeks. So 2 weeks is probably average. And when that result comes back, typically you will get both a phone call and a written report from us. The other thing I do warn people about, if you're going through the IVF process and you are planning to do the PGT testing, after you get, you'll know the number of eggs you got before you walk out the door. Most cases. You'll get a phone call the next day, and they will tell you how many of those eggs fertilized, how many of them became embryos. But then you're really not going to hear anything else from us for probably a full week, sometimes even 8 full days, because nobody wants to go and pull those embryos out and mess with them when they're trying to grow. We'd love to be able to give you an update, but messing with the embryos is probably counterproductive, because we want them growing as best they can in their little incubators and in their media. So then once they are biopsied and frozen, then you get a written report. So if you're having IVF and you're doing PGT testing, we'll take care of the family for you. Don't worry. We're on top of it. We'll visit with them, keep them company. And then you'll get a written report at the end. Both a written report and a phone call comes typically once we get the PGT results back. Okay, what else we have going on here? What is the significance of a 0PN embryo? A 0PN embryo. Well, without going into too much detail on the embryology, 0PN means 0 pronuclei. And a pronucleus is a structure that we see under the microscope when looking at an embryo. So a normal embryo is a 2PN. There are 2 pronuclei in the embryo. A 0PN means that we're just not seeing the pronuclei. So it doesn't mean that there's necessarily something wrong or that it's not there. It means that We're just not seeing it. So CNY has a policy of continuing to grow those embryos and to transfer those embryos as well. F. Zara asks, I have an FSH level that's 25.5. What can I do? Anybody know what FSH is? FSH is follicle stimulating hormone. FSH, follicle stimulating hormone. And what that tells us is that that number is starting to kind of, well, it actually also depends on when that was taken during your cycle. But the higher the FSH number, it means typically the lower the level of estrogen. So when your estrogen is low, then your body makes more FSH because it's trying to recruit follicle stimulating hormone. We're trying to stimulate more follicles because remember the cells in that follicle that make estrogen? Boy, that's the third time we're mentioning that, granulosa cells. We should have granulosa cells come visit us in our next live if we can figure out how to do that. Granulosa cells make estrogen. So FSH is trying to make more estrogen when your estrogen level is low. And when is the estrogen level the lowest in your life? In menopause. Actually, it's low before menopause. It's low before puberty, but certainly in menopause. And so we see higher FSHs as women start to approach that perimenopausal time frame. We don't so much use FSH as a predictor of success anymore. We're really more interested in the hormone level that's called an AMH, or an anti-Mullerian hormone. So if you speak to a reproductive endocrinologist for the first time and you say, I had some testing done, or if you haven't gotten there yet and you're just talking with your OBGYN, the test that you want to do is your AMH, the anti-Mullerian hormone, because while it is not predictive of your ability to get pregnant on your own in nature, it is predictive of how your body will respond to the IVF medication. So AMH is probably the better bet there. Let's see, how long does IVF take? About 15 minutes. Well, maybe that's not what you're asking. The IVF process, the stimulation process, is typically 8 to 12 days. So most people will go through their stimulation and have their retrieval usually in a half of a month. So almost like the first half of a menstrual cycle leading up to the time when your ovary would normally release an egg. So about half a month is probably what that is here. Boy, we got so many different folks here. Carly, can't wait to meet you in a few weeks. Oh, about to start stim meds. Again, welcome to the journey, and we have nothing but the highest hopes. Escobar says, a right varicocele, is it worse than the left, and how to fix it? So this is a question about testicles. Is it okay to talk about testicles? I mean, is everybody of age? I think, we can talk about ovaries, but testicles, oh. A varicocele is a group of blood vessels that if you were to feel them, they say it feels like a sack of worms, which kind of sounds gross when you think about a sack of worms in your scrotum, but that's sort of what it feels like. It is almost like some people would describe it as hemorrhoids of the testicle. A group of blood vessels that are sitting on top of the testicle that can alter the blood flow to the testicle and alter the temperature of the testicle. And this can lead to sperm problems. So, what can be done about a varicocele? It is a common cause of male factor infertility. A varicocele can easily be removed in an outpatient surgical procedure done by a urologist. An interventional radiologist can also treat a varicocele by doing what's called an embolization. And that's where they find the source of the blood vessels by a special x ray and place a liquid blocking material into the blood vessels that will cause that varicocele or that group of blood vessels to shrink. It typically takes several months for sperm to return to normal after treatment of a varicocele. And why is that? Well, the sperm that comes out today during an ejaculation was actually manufactured in the testicle about 3 months ago. And so that's why even men who have a vasectomy, still about 3 months later, need to have a semen analysis to make sure that the sperm are not there anymore. And that's typically about 3 months later. So hopefully that helps you there. Hey, we're getting closer to wrapping it up. I think we'll stay on with you for about another 5 or 10 minutes. It's about 10 minutes, getting close to 10 minutes to 5 Mountain Time, almost 10 to 7 on the East Coast. And again, Dr. Randy Fink here from CNY Fertility, Colorado. Glad to have you all with us. Great response today, and sure are happy to see everybody in this new year. After a polyp is removed, how long do I have to wait for an embryo transfer? I would say the very next month, you're ready for an embryo transfer after removing a polyp. Now, it's a little different if you're removing a fibroid or if someone is opening up the uterus, because if the muscle of the uterus is being involved, then that muscle needs some time to heal. But a polyp, since it's a fleshy growth on the inside, nowadays can be removed so easily and so quickly that you should be able to return to having an embryo transfer the very next month. How long can you freeze an embryo? Once it's frozen, it's theoretically good forever. There's no time limit on it. So that's a good thing. And here's a nice question also coming from Sally. Sally's in Trinidad, and it's a wonderful spot. Of course, you can come to Miami and do your monitoring at CNY Fertility's Miami location, Miami Monitoring Center, which is my former office in South Florida. And that's plugged directly into the CNY system. So there are many people who come to one of our facilities or to where one of our in-house monitoring stations are and will do all their monitoring in that one spot. So again, typically that's about a 2-week time period leading up to your procedure, which would be done either in Syracuse, Buffalo, or Albany, or out here in Colorado Springs. Sally, thanks so much for being with us from the beautiful country of Trinidad. And Sally has family there, and you know what? So do I. I can hook you up with people that I know. Actually, we have a lot of Trinis who are close friends in Miami. Some of my best friends in Miami were folks from Trinidad, so who aren't watching, so I could say whatever I want about them right now. Any advice for first timers that are sitting here terrified? Yes. Oh my gosh, Minx, thanks for asking that question. The biggest thing is don't be terrified, because this seems like it's a big process to have to go through. Gosh, the science that is involved with is almost mind-boggling, It really is. But the truth of the matter is that we have this whole process down so well and so seamless that it's nothing that you need to lose a lot of sleep over. People are anxious about IVF because we're worried about the outcomes. What's going to happen here? How long is it going to take? Is someone going to hurt me? Is someone going to embarrass me? Am I going to lose some dignity in having to do this? These are the kinds of things that we worry about. What can you do? I would encourage you, Minx, to get involved in the CNY groups. We have wonderful Facebook pages. We have wonderful people who have been through the process who will be only so happy to help you through every step of the way so that you know you are not alone, that there are countless others who have been through exactly the same thing that you have, and can really take away some of the fear factor involved with everything that's IVF. I think probably most of you guys can really appreciate the fact that other people who are involved in this process are generally pretty good people. I love hearing stories about folks who are here for a procedure who met someone in the lobby of the hotel or on the hotel shuttle or sitting in the waiting room or waiting in the clinic or on one of the social media pages. It's really fantastic. Everyone seems to be more than willing to help. And that's really one of the nicest things, I think, personally, about the CNY community. Um, Oh, Kathy's going to be starting IVF next month, trying for 5 years. Well, I think that is just wonderful. You know what, folks? I think we're going to start to kind of try to wrap it up. I apologize to those I wasn't able to get to, but so many great people who were involved in this live today. I'm here every Tuesday, and I sure hope that you will be too. I want to answer your questions. I want to talk about everything that's interesting to you, not just from a fertility standpoint, a women's health standpoint, our sexuality, our psychology, the way that we feel, the way that we act. This is all part and parcel to what makes us who we are. And at CNY Fertility, we embrace that in you, and we want nothing more than to help you with your family. So let's grow it. And more importantly, let's grow it together, CNY Nation. Thanks for being with me, Dr. Randy Fink from CNY Fertility, Colorado. We'll see you next Tuesday. Thanks so much for being here. Fink and Friends. Good night. Have a great week.